Hi everybody, welcome back. We are going to dive into chapter 27 now, which is going to have to do with surgery of the ear, nose, pharynx, and larynx. So we will call this ear, nose, and throat. This is our ENT chapter. All right, as usual, we're going to start out with some surgical anatomy, a little bit of a review here. All right, the external ear is going to include the outer surface of the tympanic membrane. That is what TM is going to stand for here. The auricle or pinna, the external auditory meatus, and the external auditory canal. The auricle is a cartilaginous structure. It's covered with skin, and its function is to gather sound waves. Okay, and we have this slide from our book. This right here is our auricle or pinna. Okay, the center contains the external auditory meatus. This is right here. That's our meatus, remember, as an opening. And the lateral third of the auditory canal is surrounded and lined with glands that secrete cerumen. Cerumen is otherwise known as ear wax. Okay, it's going to terminate at the tympanic membrane, which serves as a barrier between the external and the middle ear. So again, out here we have our auricle or pinna. Here is our external auditory meatus, our external auditory canal, and it's going to terminate here at our tympanic membrane. All right, moving on to the middle ear. This includes the tympanic membrane, the ossicles, which are the malleus, stapes, and incus, the eustachian and tube opening, the opening of the mastoid cavity, and the intratympanic portion of the facial nerve. So going through each of these just a little bit one by one, the tympanic membrane is both elliptical and conical in shape, and it aids in the process of hearing. It's going to transmit the sound waves to those ossicles. All right, so if we're looking here at the diagram, here is our tympanic membrane, and our ossicles are going to be these three little bones right here. 1, 2, and 3. And they're going to open into the oval window, which is right underneath where my pointer is right now. Excuse me. So the malleus, also known as the hammer bone, is the most lateral, and it's partly embedded into the tympanic membrane. Okay, the incus is going to follow it next. That is the anvil, and it connects the stapes and the malleus. All right, the stapes, also known as the stirrup, transmits vibrations of the membrane, tympanic membrane, and the other ossicles then to the inner ear through that oval window. Okay, the eustachian tube is composed of connective tissue, and it's lined with a mucous membrane, and it extends to the nasopharynx at the distal end, and it assists in equalizing pressure. All right. Something that is a little bit clinically significant for us regarding the eustachian tube is that bacteria can spread through that tube from the nasopharynx, and that's what's going to cause otitis media, or our middle ear infections, which everyone knows are not pleasant. All right, moving on to the inner ear then. This is composed of a series of hollow tunnels. They're called labyrinths. We have a bony labyrinth formed by the temporal bone and filled with perilymph fluid. And then we have a membranous labyrinth, and that is going to include the cochlea, semicircular canals, and the vestibulum. All right, so here we have our cochlea, and our semicircular canals are up here, and then the vestibule. All right, the cochlea is the spiral shape. It contains the cochlear duct and the organ of Corti, also known as the organ of hearing. It extends along the length of the membranous labyrinth, and it's lined with cilia. Okay, the semicircular canals communicate with the middle ear via that oval window and also the round window. Each canal is going to contain an enlarged place called the ampulla, and the crista ampullaris is located in the ampulla. It is responsible for equilibrium of the body when it's in motion. So that is also known as dynamic equilibrium, and that is what those structures there in those canals are responsible for. Okay, going on to sound transmission in the ear. So hearing is the neutral interpretation of sound transmission. Sound waves in the ear are going to enter the ear and they're transmitted to that tympanic membrane. Okay, the membrane is going to vibrate against the malleus, remember, which is attached on the posterior side of it. And it's going to cause vibration then in that incus and stapes, which is going to go through the oval window. Then the sound is transmitted into the perilymph of the cochlea, through the vestibular membrane to the basilar membrane and the organ of Corti. And this slide here, this image is from your book and it demonstrates the path and traveling of that sound wave then through the cochlea and out. All right, clinical examination of the ear is going to include the external auditory canal, the auricle, mastoid, and surrounding tissues. They are examined for signs of infection, inflammation, neoplasm, if you remember, is cancer tissues, scars and lesions. The otoscope is used for the initial examination of the tympanic membrane. Microscopic examination may be performed, usually with a 250 millimeter lens and an ear speculum. And nasal and oropharyngeal exams are usually performed with a tongue blade and a pen light for blockage of that eustachian tube is what we're looking for there. And then as with any other specialty, we have the CT and MRI available as well. All right, positioning for these patients is generally supine with the head turned to the side, with the operative side up. Donut is used to stabilize the head and to keep pressure off of that non-operative ear. Remember, these gel donuts, these donuts are gel filled, so that will keep the pressure off of that ear and prevent a pressure sore. And as with eyes, it is very important that these patients remain still. We can cause injury to the ear under a microscope just as easily as we can cause injury to an eye. So we do not want that to happen. All right, prepping and draping for these procedures. We are going to focus on the ear and the post-auricular area. However, the circulator will end up prepping the site extending out to the cheek, eye, temporal bone, and upper neck, depending on the procedure. Okay, if we are doing that extensive of a prep, we will normally use betadine. Some prep solutions are ototoxic and they can cause damage to the ear, so betadine is our safest bet. A sterile cotton ball can be placed in the ear canal to prevent any prep from entering. The ear is draped with 4 towels and covered with a fenestrated transparent drape. This may or may not be stapled in place. If the transparent drape has adhesive, then obviously we do not need to staple those towels. And then finally, a fenestrated drape is going to be placed over those towels and the transparent drape to complete our sterile field. If a skin graft is needed, is needed for any reason, then we will also prep and drape a second site. Instrumentation used in the ear surgeries. The primary instruments used here are going to include plastic surgery instruments. They're going to be small and very fine and delicate. Some hook retractors, mosquitoes, 15 blades, Adsons, small Metzenbaum scissors, tenotomy scissors, graspers, picks, elevators, etc. Okay. Various sizes of ear speculums are available in the sets. They are designed to fit into the ear canal without any kind of external support. However, if the surgeon prefers it, there are speculum holders available that allow the surgeon to use both hands when operating. And then we can use otologic endoscopes. These are going to allow the surgeon to visualize parts of the ear that are difficult to see otherwise, and those do require then a light source. We'll move on to some equipment and supplies. Not uncommon that we will need power drills in any surgeries involving bone, such as opening a mastoid bone to enlarge that bony portion of the ear canal, or drilling through the stapes footplate if we need to work on the inner ear and middle ear. All right, so we will need a power drill for those. These are microscopic drills. They are used with small cutting or diamond burrs, which we will get into in detail when we hit the orthopedics chapter. The important thing to remember when using these is that the tips need to be irrigated when they're in use to prevent tissue heating. So when we are using these burrs against bone, we've got metal on bone spinning at a very high rate. Heat is produced and the tips of these burrs do get very hot. So normally what we will do, because we're usually working under a microscope at this point, is we will put a blunt needle onto a syringe and just drop some irrigation on top of that burr, a couple of drops at a time, to keep that heat down and to make sure we are not obscuring the surgeon's field of view. Right. Not uncommon for us to use a microscope during these procedures. If we are using that, it's used in all procedures of the middle ear. Course adjustments are made before surgery, meaning focus, size of the visual field, things of that nature. And then it needs to be draped within an hour of use. We do not want to drape the microscope too early before our cases. It is entirely possible that someone could come into the room and unintentionally or unknowingly contaminate that microscope. So we want to make sure that we're draping it as close to the surgical time as possible, as with any setup. All right, sponges and dressings used in these procedures of the ear are going to include 4x4s, Ratex, laps, cotton pledgets, and cottonoids. Remember, cottonoids are our patties. All sponges and sharps are counted for these procedures. And there are two types of dressings that are used for these. The mastoid dressing is used after complex procedures. It consists of several fluffed gauze sponges to cover the ear and incision, as well as a rolled gauze that we call curlix that is wrapped around the patient's head. And then we have the glass cock dressing. This is used after minor procedures. It comes prepackaged, and it's usually just some gauze sponges with some Velcro straps that will help hold them in place. Medications used for ear surgery are going to include anesthetics, hemostatics, antibiotic solutions, and irrigations. Lidocaine with epi is usually used to control bleeding. That's going to be our anesthetic most commonly used. Gel foam and Helostat are our primary hemostatic agents that are used for these. And what we'll do is we'll take a gel foam, we will soak it in a corticosteroid. That's often used at the end of the procedure to help with post-op inflammation. Right, so moving on from the ear into the nasal cavity, and that's going to include our oropharynx and our larynx as well. We'll start with some surgical anatomy again. Okay, we are going to start with the external nose. This includes two lateral cartilages, two upper lateral cartilages, two nasal bones, our flares, otherwise known as our nostrils. These are lined with skin and small hairs that filter the air. And then the flares are divided by the septum, and that's going to make up our external nose. All right, moving on to our nasal cavity. This is located over the palatine bone, which is the floor of the nose. The cribriform plate and ethmoid bone are going to form the roof. These separate the nasal cavity from the cranial cavity. Infection or disease from the nose may enter the cranial cavity. That is a little bit of a clinical significance that we need to know regarding the cribriform and ethmoid plates. Paranasal sinuses are formed by extensions of the ethmoid, frontal, maxillary, and sphenoid bones, and then obviously our sinus names will match that. The extensions are referred to as turbinates or nasal concha. So just a little bit on the sinuses. As air passes through the sinuses, it is warmed, humidified, and filtered. Nasal cavities drain into superior, inferior, and middle meatus. The nasal lacrimal duct drains into the inferior meatus. And the posterior aspect of the nasal cavities is called the choana, which separates them from the nasal pharynx. This is clinically significant because some infants are born with what's called choanal atresia. And in this condition, one or both of those are obstructed. So this is actually going to require an emergency surgery so that we can restore airflow to that little one. All right, moving on to the paranasal sinuses. These are going to include the maxillary sinuses, which are paired large sinuses below the ocular orbits. The tooth roots are also found here. Okay, the frontal sinuses lie behind the lower forehead. Our ethmoid sinuses are small air cells in the lateral wall of the nasal cavity, between the lateral nasal wall and the turbinates. And the sphenoid sinuses are posterior and superior extent of the nasal cavity. So they are up top and kind of back behind. All right, the optic nerves and the carotid arteries lay behind this sphenoid sinuses, and the pituitary gland is above them. Right? Surgery of the pituitary gland may be performed through a transsphenoidal approach. That narrow nasopharynx is situated behind the nasal cavity above the oral cavity, and it communicates with the nasal sinuses and the oropharynx below it. All right, but what I want you to take away from there is that surgery of the pituitary gland may sometimes be approached through those sinuses. All right, moving on to the oral cavity. It does have two sections. The vestibule lies behind or between inner surfaces of lips and the buccal mucosa, or our cheeks, and the lateral aspects of the mandible and maxilla. Okay, the oral cavity proper lies within the medial surfaces of the maxillary and mandibular teeth. The floor of the mouth contains ducts for submandibular and lingual salivary glands, and the frenulum attaches the tongue to the floor of the mouth. All right, something to take away from this is that the roof of the oral cavity proper consists of the hard and soft palates. Those are what's going to separate it from the nasal cavity. And the soft palate, another term that I would like you to be familiar with, is going to meet in the middle and form the uvula. And all of that is diagrammed here for you. This is another image from your text, so you can refer to it there as well. All right, the pharynx. This is a tubular structure extending from the nose to the esophagus. It's separated into three areas. Okay, we have the nasopharynx, which extends from the posterior concha of the nose to the palate. The adenoids lay in the posterior asduct, and the eustachian tubes open on each side of the adenoids. That is why it is not uncommon if your child gets ear infections quite often, they will oftentimes check those adenoids as well. It's not uncommon for adenoids to need to be taken out if ear infections are constant. Okay, then we have the oropharynx. This is going to extend from the palate to the hyoid bone. The soft palate, tonsils, and posterior third of the tongue are going to lie in the oropharynx, okay, so the back of the tongue. And then we have the hypopharynx, and this extends from that hyoid bone to the esophagus. And those structures are labeled here as well. And this again is from your textbook, so you can reference it. All right, the larynx is composed of 9 segments of cartilage. We have 3 paired sets and 3 unpaired sets. The paired sets are listed here, the arytenoids, corniculate, and cuneiform segments. And the unpaired sets are the cricoid, thyroid, and epiglottis segments. All right, the larynx is separated into 3 spaces as well. We have the supraglottis, which lies above the true vocal cords and contains the vestibule, false vocal cords, and the epiglottis. We have the glottis that extends from the true vocal cords to about 1/2 inch below the true vocal cords. And then we have the subglottis, which extends from the end point of the glottis to the inferior edge of the cricoid cartilage. All right, the arytenoid cartilage lies in the posterior larynx. and it does have some anterior processes. An area between the arytenoids is called the posterior commissure. Right, the true vocal cords meet anteriorly at the anterior commissure and connect to the thyroid cartilage. The free edge of those true vocal cords has a membrane that vibrates to produce sound. And then another little bit of information here is that the trachea extends from the cricoid to the carina. It is composed of 20 incomplete cartilage rings. The cricoid is the only closed ring around that trachea. The posterior aspect of the trachea has no cartilaginous structure. Right, some diagnostic tests that we may do are going to include endoscopy procedures that are performed for direct visualization. So here we're talking about our sinuscopy, laryngoscopy, or bronchoscopy. Operative procedures may include biopsy and removal of small lesions or pathology specimens obtained with tissue removal and cell washings. And then we have our imaging studies such as our CT and MRI. Right, prepping and draping of these patients is going to include the face. The entire face is prepped for nasal procedures from the forehead to the upper neck. Okay, where it says no prep here, intranasal and endoscopic procedures do not need to be prepped. They are considered clean contaminated procedures. They are not sterile. All right, for nasal procedures, a 3/4 drape is going to be placed under the patient's head, and a head drape is going to be applied. The face is toweled off and a split sheet used to cover the rest of the body and frame the face. All right, and the procedures of pharynx and larynx, they're approached transorally, and little to no prep is needed for those as well. So obviously our prepping and draping is going to be dependent on what procedure we are doing. Here you will see an example of a head drape. Here's that 3/4 underneath the patient's head. And then we'll put the head drape around, and what we mean by that, it's usually just a half sheet that we will kind of make a bit of a turban through, and we'll either place a small staple right here or just a towel clip to hold that onto the patient, and we can drape their face then from there. Right, some equipment and supplies that we will use for this portion are going to include, first off, a microscope. When we are working in the throat, we are looking at a 400-degree lens. No drape for procedures of the mouth or throat are going to be needed. And the ST is going to need to guide instruments into the laryngoscope if we are working in the throat, as the surgeon's not going to want to take his eyes off of that field. Sponges, again, are going to include cottonoids, which are our flat surgical patties, cotton pledgets, round gauze sponges you will see here. Sometimes Kittners and peanuts may be involved. It's going to, again, depend on the surgery. One thing to note with these ENT sponges is that they all have strings sewn into them. That is so that we can identify them, and it is a bit of loss prevention. We know where they are. We can grab those strings. They will not get lost. One thing to keep in mind as well is that anything that goes into the throat, if we, for instance, are putting any of these round sponges in during a tonsillectomy, they need to be counted and then counted when they come out. And always, always make sure that somebody besides you and the surgeon knows that there is a throat packing in. Let your circulator know we've put in a throat pack, or one gauze in, or whatever your verbiage wants to be, but always make sure somebody else knows. All right, dressing for these procedures. There are no dressings applied to the mouth and throat. A variety of nasal dressings depend on the procedure. Inferior or interior nasal passages may be splinted, or they can be packed with a 1/4 or 1/2-inch gauze strip that may sometimes be impregnated with betadine or iodine as well. And then we also have the external nasal splints that we're all familiar with. One thing to just expand a little bit on packing the nasal passages, that is the process of placing long strips of fine gauze material into the nose. It adds support and kind of helps with fluid absorption as well. It does help control bleeding and drainage after a septo or rhinoplasty. So it's usually, like I said, 1/4 to 1/2 inch in width, and it is very, very long. So normally it comes in a plastic container. We will pass it with forceps on the very end, and our surgeon will just keep packing it in that nose until we are satisfied with the length and the structure that's in there, and then we will just clip it off at the end. All right, some medications that may be used are going to include regional anesthetics, vasoconstrictors. Remember, we can use cocaine in ENT, but it is topical only. Very important. We also need to make sure that we are labeling very clearly what we have. Okay, we might use some decongestants, and we might use local anesthetic that's injected into the nasal mucosa and the terpenates for some nasal procedures. Right, instrumentation used is going to include some different kinds of retractors, knives, elevators, forceps, and rongeurs. Tonsil and adenoid instruments are going to include the MacGyver mouth gag, tonsil snares, and adenoid curettes. The mouth gag is placed in the patient's mouth and then it's attached to the Mayo stand. We also may use a microdebrider that is used to excise tissue during nasal and laryngeal surgery. It's a small, very small actually, powered handpiece. We may also use a sinuscope to visualize those sinus passages. They come in 0, 30, and 70-degree lenses. The 0-degree lens is for sinus exploration. The 30-degree lens is for maxillary, sphenoid, and ethmoid sinus procedures. And the 70-degree lens is going to be for the frontal sinus. All right, moving into our last section here. This is going to be the neck. So we'll start again with some surgical anatomy. We're going to start with nerves, vascular supply, and muscles. So the neck is anatomically organized into triangles. Each side of the neck is divided into 2 triangles that are separated by the SCM. SCM in here is going to stand for the sternocleidomastoid muscle. Below the SCM is the carotid sheath, which contains our carotid artery, our intrajugular vein, and our vagus nerve. All right, spinal and accessory nerves are crossed posterior to the triangle behind the SCM. In the space below the SCM, larynx, pharynx, thyroid, and parathyroids are on the medial side of the carotid sheath. Right. And then we do have some cervical lymph nodes that are located throughout the entire anterior neck. So what I want you to take away from there is that the neck is divided into triangular portions for identification. Right, the salivary glands. We have 3 pairs. We have the parotid glands that are over the mandible anterior to the ear. They extend to the masseter muscle, and the tail extends into the upper neck. The parotid glands are the largest of our salivary glands. Okay, next in line for size is the submandibular glands. Those are the second largest. They are C-shaped and wrap around the lower mandible. And then we have the sublingual glands, which are the smallest, and they lie throughout the floor of the mouth. One thing that we need to know about saliva is that it does irrigate the mouth, and it contains enzymes for breaking down carbohydrates and buffers to reduce the acidity and protect against bacteria and demineralization of the teeth. So our saliva does play a few roles that are handy. And last but not least, we do have the thyroid gland. This is located mid-neck, overlying the trachea, right below the larynx. It has 2 lobes that are connected by an isthmus. Hormones are secreted by the thyroid gland that are necessary for regulating cell metabolism and growth and calcium regulation. The parathyroid glands are small glands that are situated throughout the lobes. They produce parathyroid hormone, which influences calcium and phosphate levels in the blood. So our thyroid is a pretty important gland as well. Right. From here, we are going to stop. We will go through some procedures and review in class. If there are any questions, please make sure you leave them here, and I will see you guys in just a little bit.